I'm Stefan Bertog from the Cardiovascular Center in Frankfurt. I'll briefly talk about left atrial appendage occlusion, and I think it's good to start with, first of all, is this an important topic or not? I think it's very important because there are a lot of people with atrial fibrillation. If you look at the US population, there's probably an estimate of 5 million people with atrial fibrillation in the year 2000, and that's projected to increase to about 8 to 10 million people in the year 2025 based on age and demographics. In any case, if you then look at the risk of a stroke with atrial fibrillation, you have about a 5% risk annually in all comers with atrial fibrillation to have a stroke, which then would translate to about 250,000 strokes per year that are caused by atrial fibrillation. What do we do about it? Well, anticoagulation we know has merit. It decreases the stroke risk by about 60%. There's no doubt about that in multiple randomized controlled trials. Unfortunately, however, only about a third of patients who are eligible to take warfarin are actually taking warfarin for various reasons, mainly the bleeding complications. How about the novel agents? There are novel agents such as apixaban, dabigatran, or rivaroxaban that are also effective in reducing strokes, but they too have a significant bleeding risk. So I think there is merit for left atrial appendage occlusion for the prevention of stroke. And how is it done? Well, briefly, you use a transvenous access through the femoral vein. You advance a 035 guide wire into the superior vena cava. Then you advance a transeptal sheath into the right atrium with a Brockenbrough needle ready for puncture. You puncture the intra-atrial septum, and then you advance a sheath into the left atrium. You then eventually exchange the sheath for a delivery catheter or delivery sheath, over which you then position the left atrial appendage occlusion device into the left atrial appendage. The procedure typically takes about 30 to 45 minutes. And what is the data supporting left atrial appendage occlusion with either the Watchman device or the ACP? Currently, we have two randomized trials with the Watchman device. One is called the PROTECT-AF trial. The second one is the PREVAIL trial. The PROTECT-AF data was first published in 2009. And this did show an equivalent efficacy outcome with Watchman device versus anticoagulation with warfarin. There were some safety concerns at the 18-month follow-up due to a rate of about 4% or 4.8% of pericardial effusions, and there was also some risk of about 1% of periprocedural stroke. However, if you look at the long-term follow-up data for PROTECT-AF, which was recently published, or not published, but presented, sorry, in the Heart Rhythm Society meeting in Denver, you could see that at 45 months follow-up, the safety data for Watchman versus warfarin was about equivalent. However, what you could see is that at 45 months follow-up, there was a significant reduction in stroke, and especially hemorrhagic stroke, and also a significant reduction in overall mortality, favoring device closure of the left atrial appendage with a Watchman device. Likewise, the PREVAIL data did demonstrate equivalency of device closure versus anticoagulation. The follow-up, the long-term follow-up of this study is not completed yet, so we have to wait for the data for this. But I think overall, specifically in patients who are poor candidates for anticoagulation, but even in those who are candidates for anticoagulation, I think that device closure of the left atrial appendage should be considered.